Hello everyone, hope you're all doing good. In this video, we are going to discuss about Müllerian anomalies. Müllerian anomalies are prevalent in 0.5 to 6% of women, and this is mostly diagnosed during pregnancy or any routine gynecological examination. And if you see, the prevalence of Müllerian anomalies in patients with infertility is around 25%, and the prevalence with women who are having RPL is around 13%, 13 to 14%. Prevalence of Müllerian anomalies is around 0.5 to 6% in women, and most of these women are diagnosed when they come for infertility or when they have any routine gynecological checkup. Most of the women are asymptomatic only. But the prevalence of Müllerian anomalies in women who are presenting with infertility complaints was around 25%, and the prevalence of women who is presenting with recurrent pregnancy loss is around 13 to 14%, right? So as I said, most of the women are asymptomatic, and the diagnostic methods for Müllerian anomalies include hysterosalpingogram, ultrasonogram that can be a 2D or a 3D mode. You can even go for a CT scan, MRI scan, or hysteroscope or laparoscopy also. Among this, the most commonly used method for diagnosis is hysterosalpingogram to differentiate between the various types of Müllerian anomalies, and laparoscopy is the gold standard for diagnosing Müllerian anomalies, right? Now, we shall see the classification system for Müllerian anomalies. I am going to discuss with you about the two important classification systems of Müllerian anomalies. Okay. One of the standard classification of Müllerian anomalies was given by AFS Society, that is American Fertility Society of Classification of Müllerian Anomalies. There are 7 types of Müllerian anomalies that can be seen in the uterus. Number 1 is segmental Müllerian hypoplasia or agenesis. So this hypoplasia can be at the level of vagina, cervix, even the fundus of the uterus or the tubes, or it can be a combined anomalies also. And the second type is unicornuate uterus. Unicornuate uterus means only one horn of uterus in the early embryological life is going to grow. Okay, but there can be an associated rudimentary horn also. So there are many types in unicornuate uterus as well. These include communicating rudimentary horn uterus, then non-communicating horn, or one doesn't have endometrial cavity and there will be no rudimentary horn itself. Clear? Yes. Third type is uterine Didelphys. And the fourth one is bicornuate uterus. Both horns of the uterus are going to grow normally, but they are not uniting. Okay. So this can be further a complete one or a partial one. And then we have the septate uterus. The septum that is formed after the unification of the uterus is not going to resolve. Okay. So this can be again complete or partial. Then we have the arcuate uterus and diethyl stilbestrol related complications arising in the uterus. Okay. So this is one of the standard classification that is used so far. But recently we have come across another classification system. So this is one of the pictorial representation of the various anomalies that have been discussed in the ASRM classification. So we have the hypoplasia or agenesis, and this can be present at the level of vagina. So the vaginal agenesis is there, and then the cervical agenesis is there. You are not able to find the cervix. Then you have the fundal agenesis. See how the uterus fundus is there, then tubes, the tubes are not found, and combined anomalies can also be there. The second type is a unicornuate uterus, where you will be having two horns, and which is a communicating horn. You see a communication over here, right? Then it is non-communicating. See, there is a obstruction that is coming over here. Okay, so the two horns are not communicating. And then you have no cavity at all. Means that there is no cavity means this is completely white because it is solid one. Okay, whereas here you are able to see a gap in the first and second diagram. And there is no rudimentary horn itself. Okay, and the third type is uterine didelphys. You have two separate uterine cavities. So bicornuate uterus, a complete one and a partial one, and then you have a septate uterus where there is a full septum that is coming up to the cervix itself. You are able to see it, and a partial septum where it is stopping in between. And then you have an arcuate uterus and diethyl stilbestol related uterine complications. Mostly you will be having a T-shaped uterus here. Okay, so if you see, the cavity is in the shape of T, right? So this is the pictorial representation of the AFS classification. Now we are going to see about the ASRM classification. Okay, so this is a newly defined classification for Müllerian anomalies that was given in 2021. Okay, so here we have nearly 7 classifications as we have previously seen, but one difference is they have included Mayer Rokitansky Küster Hauser syndrome or Mullerian Agenesis. It is nothing but a Mullerian Agenesis only. So we have hypoplasia of the tubes, uterus, cervix or the vagina, and then you have the unicornuate uterus or a unilateral Müllerian anomaly that is seen in 15%. So there is no rudimentary horn, there is a non-cavitatory rudimentary horn or a cavitatory rudimentary horn that can be communicating or non-communicating. Among that, remember, no rudimentary horn is the most common type, which is around 35%, right? And then you have a uterine didelphys. You have two separate uterine horns and two cervices. Okay, whereas in bicornuate uterus you have a complete type and a partial type. Complete type means the septum extends to the internal or the external os, whereas a partial one means septum is confined to the fundal region alone, and this is one type. And then you can even have two separate uterine horns and a single cervix, and then fundal depression between the two horns will be greater than 1 centimeter. Okay, so if you take the intercornual distance, then it will be more than 4 centimeter. Okay, we'll discuss it in detail while seeing each individual type. Okay, for now you remember, in bicornuate uterus, the fundal depression separating the two horns is greater than 1 centimeter and intercornual distance is going to be greater than 4 centimeter. Then the fifth type is septate uterus. In that you will be having a complete septum or a partial septum. In a complete septum, the septum extends to the internal os, whereas in partial septum, the septum does not reach the internal os. And here you have to differentiate between the bicornuate uterus and the septate uterus. If you see, the fundal depression separating the two horns is less than 1 centimeter in septate uterus, whereas we have seen in bicornuate uterus, it is going to be more than 1 centimeter. Okay, so the difference you have to know. So it is going to be more than 1 centimeter. Whereas here it is less than 1 centimeter, and the intercornual distance in bicornuate uterus is going to be more than 4 centimeter, whereas this is less than 4 centimeter, right? You have the arcuate uterus as well. That is a normal variant. The endometrial cavity is not divided. External contour of the uterus is flattened or minimally concave as well. Okay. Then you have the T-shaped uterus, which is nothing but the diethyl stilbestol related uterus in the AFS classification. Okay. So results from utero exposure to diethyl stilbestol. So hopefully with these two classification you would have got an understanding what are the different types of anomalies we can have, right? So we will pass on to the discussion of each type of uterus individually now. So with these two classifications you would have understood what are the different types of anomalies we can get during development of the uterus as well as the genital tract in the female. Now we will discuss each type of anomaly individually, right? Okay. So first one is unicornuate uterus. Incidence of unicornuate uterus is around 14%. And if you see clinically, the uterus is markedly deviated to one side. Okay. So already as I told, you can have a rudimentary horn that can be communicating or not communicating as well. Yes. Then if you see the HSG pic of unicornuate uterus, you will be having a banana shaped cavity, right? Because it is unicornuate, one horn is completely not developed. That means it will be having a single fallopian tube only. And we know 3D or MRI is more precise for diagnosis. What are the risks that are associated with unicornuate uterus? This include there is an increased incidence of infertility as well as endometriosis. Suppose if the non-communicating horn is going to contain functional endometrium, what will happen? The functional endometrium is also going to react to the hormonal changes that is happening in the female. That is also going to have the regular menstrual cycle if it is a functional endometrium. So, she will be presenting with abdominal pain and abdominal mass as well, because since it is a non-communicating horn, the blood that is collected, it is not going to be let out, right? Okay. Then during pregnancy, she can expect complications like malpresentations, especially breech presentation. There can be miscarriage, preterm labor, fetal growth restriction, intrauterine death. But you have to know this fact also. Yes, live birth is also possible in unicornuate uterus. If there is unicornuate uterus, then the live birth rate can be around 54%, right? Yes. Last but not the least, risk of ectopic pregnancy is also there. Okay, and when it is formed, there is an increased risk of rupture as well. Okay, so this is the picture of unicornuate uterus. So you have this horn only is completely developed. Are you able to see? Whereas this horn is not developed much, but it is communicating to the normal endometrial cavity. Okay, whereas this is a non-communicating because there is a solid part in between the two cavities. But however, there is a cavity separately for the rudimentary horn. Whereas here you have no endometrial cavity and here you have no horn itself. Okay, so this is the HSG pic of unicornuate uterus. See, when you give the dye for hysterosalpingogram, you are able to see that only one side the dye is being filled. Okay, you are not able to find the other side of the uterus, right? And there is no spill as well, meaning that there is a single fallopian tube that is present, right? Okay. Now, if you have unicornuate uterus, how you are going to manage the patient? So, management depends on the type of horn present. When you have a non-communicating horn, and it has a functional endometrium as well, you can either go for laparoscopic resection. Suppose if there is no functional endometrium, okay, so absent functional endometrium means, and then you have to check whether it is solid or it has a cavity. If it has a solid horn, then removal is not indicated. Okay, removal is not indicated because it is not going to cause any trouble. Whereas when it has a cavity, then sometimes you may need prophylactic excision of this horn with endometrial cavity, right? And then you have to remember, suppose if there is a pregnancy in the rudimentary horn, there is a chance of rupture before 20 weeks. And if the pregnancy occurs in unicornuate uterus, that is the normal horn, then monitoring and management can be done according to a just like repeating. then monitoring and management can be done just like a normal pregnancy, except that you have to keep in mind about the expected complication, especially the preterm, labor, or the malpresentation, that is breech presentation. Clear? Right. Now, we'll see the next type, that is bicornuate uterus. So, bicornuate uterus constitutes to about 25% of uterine anomalies, and here you have only one cervix, but you have two uterine horns. Okay. So, obviously bicornua, that means two horns, but you have only one cervix. Remember that, right? Okay. So, remember these two horns are going to be communicating as well. Okay. So, your pic of bicornuate uterus will be just like this. Okay. So, you have two cornuas and a single uterine cavity. Okay. You have fallopian tubes as well, and they are going to have a communicating endometrial cavity also. Understood? Yes. Now, HSG pic will be showing wide angle between these two horns, right? There is a wide angle around 105 degrees. Okay. So, that one you have to remember. And if you take a 3D USG or MRI, you will be able to see fundal invagination. You are able to see that normally how our fundus comes in a uterus, normally it will be like this. Okay. So, there is some elevation in the fundal region normally, right? But here there is no elevation, it is going for invagination, right? And this invagination will be more than 1 centimeter, especially when you see it in a 3D ultrasonogram or an MRI. Clear? Right. Then, final diagnosis, yes, which is the gold standard now? Laparoscopy. Final diagnosis can however be made by laparoscopy. And when we see the complications with pregnancy, bicornuate uterus has a live birth chance of around 60%, and preterm labor can occur in bicornuate uterus around 30 to 32 weeks. Okay, and you have to do monitoring of the pregnancy. Management is done by unification surgical technique. Okay, you are going to unify both the horns, that is unification surgical technique, and the surgery name is Strassman metroplasty. When you do Strassman metroplasty in these people, the live birth chance increases from 60% to 85%. Right? Okay. I am now going to discuss about the normal hysterosalpingogram as well as the uterine bicornuate. Okay. So, you are able to see the uterus, okay, as well as there is a spill of the dye that we have given through the right tube as well as to the left tube. Okay. You are able to see the spill of the dye over here, right. So, this is a normal HSG, whereas when we come to the uterine bicornuate uterus, okay. So, you are able to see that there are two separate horns like this. Yes, you are able to see two separate horns, but they are ending up together in one single cervix. Okay. However, the tubes on both the sides are going to be normal. So, this is a uterine bicornuate hysterosalpingogram. Clear? Right. Next, we will see about septate uterus. So, this is one of the most common anomaly. Here, there is a failure of resorption of the medial part of the fused Mullerian ducts. Okay. So, this is a differentiating picture to show the difference between normal repeating. So, in this picture, we will be able to see the difference between normal uterus and septate uterus. If you see, the external contour in normal uterus and septate uterus is going to be the same. Okay. Whereas, there is an invagination when you see it inside, but this invagination will be less than 1 centimeter, right? And one more point is that you can have the septum as a partial one or it can be a complete septum as well. Okay, so this is HSG pic of septate uterus. So you are able to see the invagination, but it is very less only, less than 1 centimeter. Just I want you to show the difference between uterine bicornuate uterus also, because if you see the invagination is going to extend deeply. Okay, yes. So what are all the points we have seen now? External contour is normal, then fundal invagination is going to be there, that is less than 1 centimeter, and then the septum can be a complete or partial one. Okay, so what are the investigations you will do? Investigations will include HSG, which is going to show an acute angle, okay, that is less than 75-degree angle only between the two horns, and in USG you will be able to see two endometrial cavities that is separated by a hypoechoic myometrium. Okay, hypoechoic myometrium, and the fundus is normal. Okay, but sometimes it can be slightly concave or it can even be flat. Okay, so when we see what happens with pregnancy in this type of uterus, you have, there is an association for there is an association with miscarriage, subfertility, and then malpresentations in this type of uterus, and there is a spontaneous abortion rate also. Okay, around 42%, and this is one of the most common anomaly that you will see with recurrent pregnancy loss as well. Okay, so why spontaneous abortion and recurrent pregnancy loss are more common in this type of anomaly? One, there can be implantation on avascular septum. The septum is going to be avascular. Then there is going to be diminished blood supply to the growing embryo, and there is also going to be distorted uterine cavities as well, right? Okay. So how you will manage this septate uterus? So management is ideally by surgical resection of septum, that is done through hysteroscopy, right? And when you do this, you can have a 60% live birth rate and, when you do this, you will have a 60% pregnancy rate and 45% live birth rate. Clear? Right. Next one is arcuate uterus. In arcuate uterus, you have only a slight indentation of the fundus, and the partition will be less than 1 centimeter. So here you have no adverse reproductive outcomes, or nor you need any treatment. Okay, and surgery is only needed in case of recurrent pregnancy loss when other causes are not found. Okay, Yes. So this is a hysterosalpingography picture of orchid uterus. Only you have a slight indentation at the fundus. Otherwise, this is going to be a completely normal variant of uterus. Okay. We'll see about uterine Didelphys then. So here you have failure of fusion of Mullerian ducts completely. Okay. So what happens? You will have two uterine horns and two cervix as well. Clear? So this is the picture of uterine Didelphys. You have two uterine horns, right? Number 1 and number 2, and you have two cervix as well, and you have two vagina. Okay, but not in all cases you will have two vagina. In some cases you can have only one vagina. So that condition is known as unicolous. Okay, whereas when you have two vagina, then it is called as bicolous. Okay, so this is a comparison between schematic diagram of Didelphys and HSG pig. So you are able to see this HSG pig comparison, right? You have two horns that is coming and ending separately, right? You have two cervix as well, and it is opening into the vagina. Clear? Right. Now, there is something called Ohivira. Okay. So what is Ohivira? This is obstructed hemivagina, and you will also have associated ipsilateral renal anomaly. Okay. Also you have obstruction by septum at one half of vagina, right? Then how you will be diagnosing this condition? Yes, what do you find in HSG? We have already seen. You will see two separate canals, right? Then in 3D, you will be able to differentiate it between a septate uterus. Okay. So how will be the pregnancy outcomes? So if we repeating. So let us see about the pregnancy outcomes. Pregnancy outcomes with bicornuate uterus are better than unicornuate uterus. Mostly it occurs in the right horn, around 76%, and among this the live birth rate is even more higher, that is 75% of live birth, right? So for management of pregnancy you need only close monitoring, and surgery is indicated rarely. Okay, if there is excessive pregnancy loss. Next condition is cervical agenesis. So this is also one of the rare condition. Usually it presents as primary amenorrhea or mass, that is secondary to hematometra or cyclical abdominal pain. Okay. And with this, vaginal aplasia is associated in 40% of the cases. Diagnosis can be made clinically or by an ultrasonogram or an MRI as well. Management is surgical canalization. Okay, you will get a functional uterus. And when surgery is planned, you have to use gonadotropin releasing hormones or oral contraceptive pills to suppress menstruation till surgery. Prognosis is better after surgery. Clear? So, these are the anomalies we can get in cervix. So, there is cervical external os obstruction, there is no opening to the exterior. There is cervical atresia, you are able to see the difference between this cervix and this cervix, right? And cervical agenesis, completely cervix is not developed, and there is a cervical cord. Cervical cord means there is a small extension that is coming, but cervix is not completely developed, right? Yes. Next anomaly is vaginal septum. There are two types of vaginal septum, namely transverse vaginal septum and a longitudinal vaginal septum. Okay, so this is a picture of longitudinal vaginal septum. Okay, you are able to see this one. So this is a longitudinal vaginal septum. Suppose transverse vaginal septum means it will be just like this. Okay, now we'll see the transverse vaginal septum first. Transverse vaginal septum. Incidence is around 1:2100 to 1:2000. Repeating. Incidence of transverse vaginal septum is seen in 1:2100 to 1:72,000 women. Okay. So what has happened means there is failure of canalization of the vaginal plate at the point where the urogenital sinus meet the Mullerian duct. In complete septum, you will have symptoms like amenorrhea or hematocolpos. In case of perforation, there can be normal menses, but there will be associated dysmenorrhea. Okay. So, transverse vaginal septum is further divided into three types. One is low, mid and high. Repeating. Transverse vaginal septum is of three types. Okay. It can be a low transverse vaginal septum or a mid transverse vaginal septum or a high transverse vaginal septum. The position of low transverse vaginal septum is less than 3 cm from introitus. Mid septum is between 3 to 6 cm from introitus, and high transverse vaginal septum is more than 6 cm from introitus. Okay. So, management of transverse vaginal septum. You can make a confirmation by during MRI, then surgical resection and anastomosis of proximal and distal vagina. After drainage of the blood has to be done. Clear? Right. Then we'll see about the longitudinal vaginal septum. This also occurs due to failure of canalization of the vaginal plate. So, this can be longitudinal or partial, repeating. So, this can be complete or partial, and 90% of longitudinal vaginal septum is associated with other uterine anomalies like uterine Didelphys, and this is clinically diagnosed mostly because most of the patient are asymptomatic or may have Repeating. Longitudinal vaginal septum may go clinically undiagnosed because most of them are asymptomatic. Some of the patients may have mild dyspareunia. Okay. So here also we have to do a surgical resection of septum. Okay. So we are done with most of the uterine anomalies. I want to discuss about one syndrome here, that is MRKH syndrome. Okay. MRKH syndrome is nothing but Mayer Rokitansky Küster Hauser syndrome. So it is Mayer Rokitansky Küster Hauser syndrome, and it is also referred to as CAUV syndrome, that is congenital absence of uterus and vagina. Okay. So if we take MRKH syndrome is divided into two types, namely type 1 and type 2. So type 1 consists of only isolated Mullerian anomalies. Like you will have congenital aplasia of uterus, or there is congenital aplasia of upper 2/3 of vagina. Clear? Then type 2 MRKH syndrome, you have Merck's association. That means you will have Mullerian anomalies, renal dysplasia or renal dysplasia, then CS for cervical somite anomalies, okay, and associated malformations. So what are the renal malformations you can have with MRKH syndrome? You can have unilateral agenesis of kidneys or ectopic kidneys or even horseshoe kidneys. And the skeletal anomalies may include vertebral anomalies. Vertebral anomalies like fused vertebrae, Klippel-Feil anomaly, or scoliosis. You may also have hearing defects and congenital cardiac defects as well. Especially, it can be associated with Holt-Oram syndrome or the velocardiofacial-like syndrome. And it may also be associated with digital anomalies as well, including syndactyly and polydactyly. Okay. So these are the associated anomalies. Apart from the Mullerian anomalies, you will have an MRKH syndrome. Okay. So whenever if you find a woman who has presented with a case of primary amenorrhea and you find her to be a case of MRKH syndrome, you have to do investigations to rule out other associated anomalies as well. That is the significance of defining so much anomalies with MRKH syndrome, right? Okay. Now, if you see the incidence of MRKH syndrome, it is 1 in 4,000 female births. Okay, but the etiology is not properly known. Usually it is sporadic in origin with polygonal or multifactorial inheritance, right? So finally, if we bring about the clinical features, as I have already told you, the women will be presenting with, yes, primary amenorrhea. So this will be the complaint in nearly 70 to 80% of the women, and sometimes they can even present with subfertility, dyspareunia also. So if we define these women usually have a normal phenotype, that is, they exactly have the normal female features, okay, and even their karyotyping is also a normal female karyotype. The ovaries are present, normal and functioning ovaries, because the ovaries are derived from the genital ridge. Okay, MRKH syndrome is mostly associated with Müllerian anomalies. So the ovaries are going to be normally present, normally developed and normally functional. Okay, and there is no androgen excess also. So that's why the phenotype is going to be normal as well. Clear? So while you do examination of this woman, as I told you, you have normal, secondary, sexual characteristics. Okay, so the breast development, pubic hair development, everything is going to be normal. Okay, and they will even reach Tanner stage 5. Okay, exactly normal. Okay, then external genitalia is also normal, and when we see the vagina, this alone is reduced to more or less like a dimple, okay, around a 2 to 7 centimeter depth it can be, or simply a vaginal dimple can be present, okay, and they will definitely have musculoskeletal or renal anomalies associated. Clear? Right. What are the differential diagnosis for this syndrome? The main differential diagnosis is going to be your CAIS, that is complete androgen insensitivity syndrome. See, in this syndrome, the phenotype is going to be normal female. They also have a short and blind ending vagina. Karyotype is going to be, repeating. What about the karyotype then? This is complete androgen insensitivity syndrome. So when the androgens are not acting in the periphery, what will be happening? Because there is receptor defect in the syndrome. Okay, so androgens are not going to act. That is going to lead to female characteristics. That means the karyotype is going to be of a male. Okay, so karyotype is going to be 46XY. Okay, and because of no androgen action in the peripheries, there is no axillary or pubic hair as well. Clear? So this is one differential diagnosis. Other differential diagnosis may include imperforate hymen, vaginal agenesis, or a transverse lower vaginal septum. Okay. In all these cases, the uterus and tubes are going to be normal. Clear? Right. So, how you can go for diagnosis of this condition? Diagnosis can be made by 2D ultrasonogram, 3D ultrasonogram. So, this is more accurate. Okay. But availability is limited, whereas 2D ultrasonogram is cheap, easily available. Yes. Here you will be able to find the anomalies in the uterus as well as the renal anomalies also. Okay. And then you can even go for an MRI which is more sensitive as well as specific also. Okay. So, this is also one of the gold standard method for diagnosing of Mullerian anomalies. You can go and check for the endocrine profile and karyotyping as well to rule out CAIS. You can go for IV urography, spine and limb x-rays, echocardiography as well as audiogram to rule out other anomalies, right? So, how are you going to manage this patient? So, management is mainly needed with psychological support. Okay. So, there can be neovagina creation and this can be done by non-surgical method as well as surgical method also. In non-surgical method, we will be using vaginal dilators which are also going to be the first line of treatment of these patients. Advantages include there is low morbidity and there is no scarring as well. Okay. Whereas surgical methods may include outdated procedures of creation of neovagina like McIndoe procedure or sigmoid vaginoplasty or Williams vulvovaginoplasty. Okay. But there are some recent procedures for creation of neovagina, just know the names alone. These include Vecchiati procedure, These include Vecchiati procedure and Davidow procedure. Clear? So, the timing of these procedures should be individualized and they should be done only when the woman is mentally stable to become sexually active and is going to get married. Okay. So, what are the fertility options of these women? However, the ovaries are going to be normal, but there is no uterus, so bearing of the children is not going to be possible in these women. So, you can offer them pregnancy through IVF or surrogacy. Okay. Sometimes even adoption can be suggested. So, with this, we are completing our discussion on Mullerian anomalies. We have discussed in detail about each anomaly as well as one of the important syndromes, MRKH syndrome. So, until we meet in the next video, keep going, take care and bye-bye.